Dr. G.M. Shamim, who will be conducting this session. I would like to invite all the panelists, chairperson, and moderators to the stage. Dr. M.A. Karim sir, Dr. Rajib Hussain, Dr. Shams Mohammad Noman sir as the panelists, Professor Dr. Zafar Khalid sir as the moderator, and Dr. G.M. Shamim sir as the chairperson for this session. Last but not the least, I'm thrilled to introduce the keynote speakers for this session, especially because I personally share memories with at least 3 of them from a very young age. My first mentor, essentially since birth, Professor Dr. Prakash Kumar Chaudhary, Academic Director, Lions Eye Hospital and Institute, Chittagong, and Director in Charge, Bangladesh Eye Hospital, Chattogram. Dr. Mahabubur Rahman Chaudhary, sir, Consultant Faculty Surgeon and Chairman, Bangladesh Eye Hospital and Institute. With all due respect, I can probably call him my grandpa mentor. And I've heard of him enough, known him enough to be inspired, particularly with his leadership and entrepreneurship skills, besides being an excellent, excellent surgeon. Okay. Finally, we have 2 amazingly gifted guest surgeons for this afternoon, or rather, let's say, ophthalmic giants from India, Dr. Anurag Mishra and Dr. Vaishali Vasavada. We're just going to wait for Dr. Vaishali to join on Zoom. She's not present with us here today. Dr. Anurag Mishra is here. We're just going to wait for Dr. Vaishali for a couple minutes for the Zoom session. We're still a little bit ahead of time in this session, which is a good part. And we are just taking some few minutes for Dr. Vaishali to join. And as soon as she joins, we are going to officially start this session one more time. Thank you. In the meantime, I'd like to request the house to ask any kind of questions you had remained to ask during the last two sessions due to constriction of time. You can just use this time to ask your questions to our former panelists and speakers, whoever you were willing to ask. You can just volunteer yourself from the crowd there.
So just we have some time, still 5 minutes. Dr. Bhushal is joining with the 5 minutes. Then we'll start our last session. By this time, if you have any questions, you can take from live surgery. If you want to take any question, Dr. Anurag, what is your actually tips and tricks to manage a hard cataract? Would you please?
So the strategy actually starts in the preoperative room. There are three things that I see in hard cataracts. First is hard cataract per se, individually presented to me, is not much of an issue. But if that comes with a few other complicating factors, I'll definitely look at it more carefully, like the hard cataract with small pupil, hard cataract with low endothelial cell count, hard cataract with a shallow anterior chamber, hard cataract with extreme of age group, like somebody presenting to me at an age of 92, having a hard cataract and some degenerative changes in the retina. I'll always look at it differently. On the table, the teachings they have given us a template kind that you have to protect the endothelium at all costs. The message that I would like to drive into everybody's mind is that hard cataract, however hard the cataract might be, per se does not make the patient strictly qualifying for SICS alone. It is not that the moment you see a grade 6 nuclear sclerosis, you should plan SICS. Phaco can still be done and can be done very well, provided you have the right kind of mentality and the right kind of instruments to support you. So your phaco machine has to be good, and all of us use good quality phaco machines now. The tip should be new. These are just small little changes that you need to bring about. The tip and the sleeve, I would have both of them new so that the flow is good, the hold is good, the cutting efficiency is good. The OVD has to be, as you showed in the morning, should be a soft shell arrangement so that we safeguard the endothelium. And then when you enter into the substance of the nucleus, that's where the crux lies. Plenty of surgeons, like you did in the morning, prefer to do a trench and then the peripheral parts are chopped. I don't do that. I do a direct chop in all my cases, including hard cataract. So there what I do is, I hope everybody can imagine it three-dimensionally. So I start entering into the nucleus little proximal to the center. and go a long distance in the oblique plane and then chop it. What it does is it chops the nucleus inside out. So the posterior plate cracks first and then it travels superficially. Then I rotate it 180 degrees and repeat the procedure. Once the primary chop is complete, once you have two separate heminuclei distinctively present, the rest of the procedure becomes very easy. So once you have divided it into two halves, the subsequent chopping and the subsequent removal becomes very easy. So apart from the standard teachings, these are the extra things that I would look at in a hard cataract.
Sure. So that what I think that the message is, then the hard cataract to manage the tip should be neo one. And staining of the anterior capsules is again the most important thing. Even what in my choice, even the glow is good, very good glow, but still I do a stain with the anterior capsule, the tip and blue. In case of any rexis tear, so that we can appreciate, so that we can manage that will be. And the size of the rexis, usually what we do 4.5 or 5, we have to take more so that we can enough deep. And that Anurag is individual to individual. Some say in your hand, stop and chop technique is the best technique, but Anurag's hands, that is a direct chop is the best technique. So for a stop and chop technique, enough deep, that deep depth should be enough. And not only deep, the width also equally important. Enough deep and width, it is a main key to divide the nucleus into multiple small fragments. More the number of fragments, more it is small in size, then it is very easily emulsify into the posterior plane. So Dr. Anurag in the morning, he told that whatever viscoelastic substance that you are using, that is important, but not so important. In which plane you are emulsifying the fragment, that is the main issue. In which plane. So if you can emulsify all fragments in the posterior plane, then only you can achieve the clear cornea at day 1. So that is another. So other things are, and the most difficult part is actually divide the nucleus into the chopping. So the most important parameter over here is actually vacuum. More the vacuum, more will be the holding paper. But at the same time, we have to keep in mind, we have to aspiration flow rate low so that any occlusion break, so that it will not cause damage to the posterior capsules. So Dr. Boshal is joined. So we are going to start our third sessions.
Just a minute. I have just one simple question to Dr. Anurag. You have told one thing that is very much appropriate for the best phacosurgeon. But what do you think that the beginner is also enough to do this hard cataract with phaco?
I'm not against any particular technique of surgery, ma'am. What I'm trying to say is,
No,
if a beginner,
that I'm
no,
telling
I know you're not,
your opinion.
no, absolutely. That's what I'm coming to. So if somebody is a beginner and somebody has just started phacoemulsification as a procedure in his or her practice and comes along a hard cataract, tries a phaco, fails, and then converts, it's still fine. What I'm saying is, just because I'm getting to see a hard cataract on the other side of the slit lamp, I should not jump to the conclusion that phaco is not the procedure for this patient.
No,
If we do that, then all along our lives, we will be a beginner. We can never be an expert. We can never go to that next level. So we have to push our limits. We have to decide that this is the procedure of choice for the current era, irrespective of the nuclear sclerosis. That is the message I want to drive into them. If that particular individual case is something where they decide to do an SICS, is fine. It should not be divided into categories, and based on the sclerosis of the nucleus, the procedure should not be chosen. That's what I'm saying.
Thank you, sir. So once again, I'm gonna formally announce the names of the panelists and moderators, and I would like all of them to take their chairs on the stage. Dr. M.A. Karim sir, Dr. Rajiv Hussain, Dr. Shams Mohammad Noman as the panel of experts, Dr. Professor Zafar Khalid as the moderator, and the chairperson, Dr. G.M. Shamin. Please have your seats on the stage. And welcome, Dr. Vaishali. I express my heartiest gratitude to Dr. Anurag sir, Director of Radharamam Hospital, Cuttack, Odisha, to be present amongst us physically and bringing along the blessings all the way from the land of Lord Jagannath here. Now, we all know him very well till now, and it's very fortunate of us to have seen you demonstrating your years of experience in surgical techniques today in the morning, along with some great tips that you shared during the live surgery. And again, we are hoping to have an enriched talk from you in this session as well. Congratulations on your successful 75th surgery in Bangladesh, and we are truly glad and humbled to be a part of your valuable memory. And finally, Dr. Vaishali Vasavada, Consultant Adult and Pediatric Phacosurgeon and Medical Director, Raghudeep Eye Hospital, Jaipur and Ahmedabad. No introduction is needed for her formally, as because she already shares a very warm familiarity with our land. She has been here multiple times, and today she will be joining on Zoom, still committing as usual to join amongst us, despite her busy schedule. And I don't know, ma'am, if you can see me or not. This is Purnashri here. And I must say, I'm very fortunate to be present here today to introduce Dr. Vaishali, who is tremendously talented young cataract surgeon from India and an inspiration to many rising ophthalmologists. I myself had the privilege to know her since I was a kid, and yet today she shines bright with her evergreen, humble smile and the sharpest mind in her field of expertise. I'd now request the moderator, panelists, and the chairperson to formally start this session for the last Master Talk session of this afternoon. Thank you.
Thanks to all. Very most welcome. This good afternoon. Now, in this session, I would like to request Dr. Prakash Kumar Chaudhary, please deliver your valuable presentation. Thanks.
Respected Chairperson, moderator and panelists, and my delegates, respected delegates, good afternoon. So I'll share my somewhat case scenario with all of you. And this is the first case. It was a white hard cataract with anterior plaque. So it was a white hard cataract with calcified anterior plaque. And the challenges were here. The making a complete optimum size axis. As it is a long standing cataract, the capsule is very thin and fragile. The joints are weak, and the fibers are very leathery and tenacious. So complete anterior posterior division of the nucleus is very challenging over here. And my first strategy is to make a small opening in the anterior capsule, and I'm using 26 band needle to pierce the anterior capsule, but it is very difficult to pierce because the plaque is firmly attached to the capsule. Now I'm using a micro scissor to the side port and give a cut in the anterior capsule, and now I'm with the Rexis forceps. I'm beating an opening in the anterior capsule. The capsule is very friable. Anyhow, I achieved a small opening, but though the Rexis margin is very irregular. Now my next plan is to extracting the plaque from the endothelium with the spatula, I'm trying to separate the adhesions between the capsules and the plaque. Now with the microaccess focus, I hold the plaque and take it out. So my first job is done. You can see here there is a 12 proportion, there the tear is there. So now with the using an axis forceps, I convert it into circular fashion, and it is a very hard cataract. So it demands large axis to deal with the nucleus. So with the micro scissors, I give a cut on my right side. Now with the using the axis forceps, I another axis. After successfully complete the axis, I proceed for starting with the hard cataract. I'm using 90% optional ultrasound. And my irrigation fluid is only using 50 centimeter to avoid undue pressures on the zonules, because it is a long extending cataract. There is a possibility of zonulopathy. And my aim is to create a very deep and wide group so that I can divide the nucleus into multiple response fragments. After achieving appropriate depth of reference, I proceed for chopping. Discovering top technique, the favorite technique to do with the hard cataract. Here I'm using 650 plus bacon. More the bacon, more with the holding power. And but I kept my expression for it is very low, so that if there is any occlusion back, it can there is a less chance of possibility to damage the posterior capsule. And it is a hard cataract, so divisions of the anterior capsule is very difficult. And after doing that, here I am using the dispersive ability to take care of posterior capsule, to take care of corneal endothelium. You can see I repeal again the equation of the viscoelastic substance. Now I go for fragment removal. The important thing is over here, you have to emulsify the fragments in the posterior plane. So to achieve clear cornea on day one, here I am using the torsional ultrasound with the interrupted pass mode to save the energy. And it is very, I'm also, after successfully emulsifying the fragments, a single disposable IOL is implanted in the bag. The second case, it is a routine cataract. As you can see over here, even hydrodissections with a band hydrocannula, hydrocannula. Here you can see the xerox. But I decided to continue phaco, and I kept my bottle height only 60 centimeter, but I'm using appropriate ultrasound more than 70%, so that there is no undue pressure on the capsular bag and the anterior capsules, and I avoid the rotations of the nucleus. And after doing that, here I am using Ascorin top technique to divide the nucleus. And here also I kept my bottle height very low, only you see only 50. And corresponding, I have also very low aspiration fluid, only 20 cc per minute. Then I proceed for fragment removal. And during fragment removal, it is very important to use optimal fluid parameter. So, and torsional ultrasound with the slow motion phaco is very useful to deal with the cataract with the axis here, because it has outstanding probability even with the lower fluid parameter. So without rotating the nucleus, I emulsify the fragments from the and one thing is that first heminucleus I emulsified, but one heminucleus is kept close to the rexis here. So nucleus and epinucleus is taken out unevenly. Now before taking the irrigation food, I'm injecting the dispersive to maintain the stability of the appendicle, which is very crucial to prevent the peripheral extension of the tear. Now I proceed to aspirate the cortex. First I'm aspirating the cortex away from the rexis here, and I'm using the bimanual IA, because again I'm injecting OBD. Every time I try to maintain the stability of the anterior chamber. Now very cautiously I'm aspirating the cortex close to the rexis here. Again you can see my bottle height is only 60 to 70 centimeter, because now you can see every time the flap tear is over here, it is egotic and fluttering, which is described as a Rohitom Prakash. That means the tear is not extended behind the equator, and I am in safe position. So every steps of the surgery, I carefully watch the flap tear. Now I proceed to implant one single piece IOL into the bag, keeping the haptic perpendicular to the rexis under cohesive OBD. Everything looks fine. Now I go ahead to remove the OBD. You see in my bottle height only 50 centimeter, only 50 centimeter. But what happened here? Even then, the lens is tilting. So I guess something is wrong. Initially, I thought that my haptic engages with the resistor, but it is not. So I try to dilate it, and but still I could not. I am not satisfied. So I proceed to consider the people. I thought that it is okay, that it will be okay anyhow. But you see, now there is a prominent start. That means the tear at that extent behind the equator. So I inject the dilated triamcinolone to see any presence of vitreous disturbance. Yes, there is a vitreous disturbed, and if it's in there is more discentrations of the ion. So now I decided to take out the four-level ion. First, I take out one haptic out of the main incision. Then we firmly hold the lens on the side port. I cut the lens to cut and take it out. Now I proceed to do anterior vitrectomy. Here you can see the vitreous extent, and I keep my cutting at maximum 4,500. And now I use 4 iris which is being used to see the status of the pupil, status of the anterior capsule. And I decided there is enough subordinate, so I decided to implant the multiple iris into the sulcus, and everything, the iris position looks normal, and the divide is taken. Again, triamcinolone is injected to see the presence of any vitreous impair. So the lens is very good in positions. So you can say this is the first postmortem. There's some corneal edema is there, but still the lens is very good. So the main key pulse to manage this case about rotation. And slow motion phaco with the torsional astalasam, it is the best option, and always maintain the stability of the anterior chamber in every step of the surgery to prevent peripheral extension of the tear. Always try to keep in mind the avoid undue pressure from the capsular bag and anterior capsule, and try to work away from the resistor. Always inject OBD through the side port before take up the irrigation handpiece, and tangential cortex involved with the bimanual IA is the best option, because with the bimanual IA, the irrigation and respiration handpiece are separate, so they greatly maintain the stability of the anterior chamber. Single piece IOL in the back with the orient, keeping the haptic perpendicular to the resistor is the best option. But multi-piece IOL in the sulcus might be possible if enough posterior capsule or anterior capsule support is there, in the posterior capsule is compromised. And always inject dilated triamcinolone to confirm the presence of any vitreous disturbance. So this is scenario 3. You can see this is a pediatric traumatic cataract. Here the main surgical challenge is making a complete perfect access, because you can see there is a defective anterior capsule at periphery, and the capsule is very thin. So back preparation of the eye will also very difficult. So after extending the anterior capsule under ear bubble technique, here I'm using the cohesive OBD to replace the tip and glue, and you can see over here the rexis run into periphery. So 4 iris again is being used to enlarge the pupil, and first with the direct 26-gauge escape needle, I puncture the anterior capsule, because in pediatric cataract the capsule is highly elastic. Then for the skyport, using the micro-rexis process, every time I hold the base of the tear capsules and pull it towards the corneal endothelium, that is centripetal. This moment I thought that the rexis run into periphery, so I hold the flap close to the tear and pull it tangentially, then towards the corneal endothelium to retract the rexis. Okay, and to another rexis, I give a cut from the other sides, and using the micro rexis process for the side port, again, I'm trying to create an optimum size rexis, and I'm lucky to have a very good optimum size rexis over here. So the soft cortex is removed to the bimanual eye. Here you can see there is a fibrotic cortical matter. It's not coming with the input, so I cut it with the macro scissor. Now you can see the posterior capsule is very thick and fibrotic because of chronic inflammation. After making an opening into the 26 middle here, I am injecting the cohesive OBD into the barrier space. Now I have to create opening in the posterior capsule. That's what I like to do with the bimanual approach with the micro scissors and micro rexis forceps. So a good opening I achieved. Now I proceed to implant a single foldable iron into the bag. And again, I inject the triamcinolone acetonide to check the presence of vitreous into the vitreous. There is nothing, and bite is taken in the side port and main port. The case is over. This is another pediatric traumatic cataract. So here you can see there is a scar corneal scar and dense posterior synechia. Here the main surgical challenge is that I don't know what is the status of the posterior capsule and anterior capsule, and I'm not sure whether the back placement IOL will be possible or not. So I start with the first I'm injecting the dispersive OBD through the sideport after making the sideport. Then under the dispersive OBD, I'm injecting the cohesive OBD and ideal soft cell technique to take care of corneal endothelium. Now I'm trying to separate, release the adhesions. Here I'm using a spatula to separate the adhesions between the, but it is very dense. So I'm using over here the micro scissor to cut the adhesions. It is fibrotic and it is very dense and fibrotic. So I use 4 items over here to enlarge the pupil. And now, now I give a cut to the micro scissor in the anterior capsule. To create an opening in the anterior capsule. Now the same technique, same principle. I'm using the micro scissors for the sideport, and now I'm in the hydro procedure. The soft way I take out in the anterior capsule. Here I'm in the vitreous cutter to take out the soft lens cortical matters, and I'm lucky that that is done very nicely. So now I proceed to inject a single piece IOL into the bag, directly into the bag. So, but I have to create opening in the posterior capsule. Here you can see there is a dense fibrotic material that I'm cutting the micro scissor and take it out. Now, again, I'm injecting the OBD through the sideport before take out my handpiece. Now I proceed to for vitrectomy to open the posterior capsules. Here I'm using the maximum cut rate 4,500. And but I kept my aspiration flow rate is very low, only 15 cc per minute, and Bitcoin is only 300 moderate Bitcoin. 300 millimeter marker. Here you can see there is a very nice decent opening in the posterior. So I'm is again injected to see the presence of it. Now I'm irrigating the anterior chamber with the BSS to check any presence of it, and bite is taken in the main port and side port, and case is over. Thank you so much for presence here.
Thank you, Dr. Prakash. Thank you, Dr. Prakash. You have given us wonderful examples of difficult cases and how you manage this with your expertise. I will request Dr. Rajiv, if you have any comment on this.
Thank you, Dr. Prakash. The excellent presentation you have seen. The pediatric cataract, which especially you have done some challenging thing, the cutting of all the tags and all these things with the bimanual. Rather than bimanual, we can use the phaco probe or not. I think it's safer rather than bimanual AC maintaining and this thing. For can we use any expert panel? Maubhai here, Anurag here. No, anterior capsule tag. You're there. You showed some tag on the pediatric cataract with the traumatic cataract. You cut with the bimanual. Fibrotic tags, all this thing. Yeah, that's right. Yeah. Okay. Okay. AVT cutter will be better, I think. Yeah, he's.
The vitreous cutter, is it on? Am I audible? Yeah. So the vitreous cutter can be used, you're right, but the settings would change. You would have a lower cut rate for the capsule cutting and the any structure that is close to the capsule in its physical structure. But the kind of adhesion that your patient had, it will not be cut with the vitreous cutter. It will fail to cut that. So earlier on, when I was a fellow at Arvind, we had a payment vitrector. That was a vitrectomy machine. It was not a phaco machine which had a vitrectomy cutter. It was a vitrectomy machine built by Payman. So the Payman's vitrector had a 19 gauge vitrectomy. It was used for anterior vitrectomy. The cut rate was low, but it was very efficient in aspirating. The vacuum was low, the cut rate was low, but the efficiency was very high. So if you have something like that, it might just cut, but otherwise these are very densely fibrotic membranes. Impossible to cut them with a vitrectomy cutter.
That's what I'm. Thank you for the question. Thank you very much.
So, I will, from the audience, if there is any question, we can take one or two questions. Anything particular? Okay. Okay. So, Aisha, yes,
I
yeah,
have a
Doctor.
question.
Dr. Boishali, you want to have give any comment about Dr. Prakash's presentations?
So thank you very much and very good afternoon to all of you and my heartfelt gratitude to Professor Prakash, Professor Mahabubur and all my friends, my seniors, my colleagues, Maziba. That was very, very kind of you and Ishtiaq, everybody there. So I think there were 4 cases in all and all of them had such a nice points, each of them. The first 2, the fact that the dense cataract, like Dr. Anurag was talking in the previous session, that just being a dense cataract itself should not preclude us from doing what we normally do with all of our cataracts. And the way Dr. Prakash managed that first dense cataract, and I saw, I mean, very patiently and very slowly he managed everything, which was a great pearl to learn. That don't get worried or panic that 5 patients are waiting or I need to finish in half an hour. You can take your time and just be slow. And the other case of the split capsule, was again a very, very same example of being patient and doing the right thing, not changing your plan because something went wrong. But at the same time, when something did go wrong, like when you saw that the IOL was decentered, there was a PC rupture, then act. Don't leave it there. The tendency natural is it's in the bag. Sometimes we try to ignore this. It's slightly decentered. Let me put pilocarpine and close the case. So that's not what we should do. What Dr. Prakash showed was an ideal example of how any complication should be managed. And I think again, the pediatric cases were brilliantly done. And I don't have anything to add except for the fact that it was a combination of technique, of instruments, and just having a strategy or a plan before we start, and a plan B, that if this doesn't work, I have a 3-piece in a backup or I have my vitrector ready. So I think all in all, brilliant presentation. Thank you.
Thank you. Thank you, Dr. Vaishali. Dr. Anurag, you want to say?
Just a small comment before. Why is it echoing?
Hello.
I thought it was echoing. Yes, it is. All right. So the only tip that I wanted to highlight here is there are 2 types of capsular extensions that happen, the rhexis extensions that happen. One is due to internal lenticular pressure, the kind of appearance that we get to see in an Argentinian flag. The other is when it is produced with the instruments, like what happened in your case. So what happened in your case was the capsular extension happened because of the hydrocannula that you took very close to the. Is it better now? Yes. So when the rhexis extension happens, no, the same echo is coming. Vaishali, can you put yourself on mute? You're muted already.
I am muted, yes.
I don't know why the echo is coming. So when the rhexis rips due to the intralenticular pressure, it is very likely to reach the zonular insertions and then proceed towards the instrument. It is likely to fall short of the zonular insertions. So if it is falling short of zonular insertions, it usually does not extend beyond the equator. So when it is due to an instrument, more likely that you would come out of it without any further danger. Even if you are unable to locate the flap motility sign, it usually does not extend. It usually doesn't extend to the posterior capsule. But if it has happened due to the lenticular pressure like an Argentinian flag, you need to be very, very careful, because that is something that that is very likely to proceed beyond the equator and go to the posterior capsule. That's just one differentiating feature that I wanted to highlight.
Just one. My knowledge may be very shallow, like I'm still not at this stage, but I would like to ask just one simple question from the last case that you did with the very hard, like fibrotic tissue case. What could be the possible complications outcome if, let's say, if we're not able to chop the fibrotic scar properly or did a lot of traction on that somehow?
Yeah, the main challenge in the pediatric cataract, our first goal, first aim, any single piece, because the pediatric cataract, the inflammation is more. If you put you cannot implant any single piece in the sulcus, that is possible. So if the posterior capsule support is not enough there, then we have to make a plan to multi-piece IOL into the sulcus. But anyhow, we always try to avoid the multi-piece IOL in the sulcus. So that is the one challenge. And the main thing is the posterior capsule. As you have seen all the time, this is the chronic inflammation of the posterior capsules become opaque and fibrotic. So you have to open up. If you cannot create an optimum size opening in the posterior capsule, the vision will not be improved. That's how we can do. Then the first is that it was so thick and fibrotic. So there is a different approaches there in every surgeon. In some surgeons, they are comfortable. It depends on which technique the surgeon is comfortable. So I have shown two techniques. In the first case, after injecting the cohesivity into the Burgess space, then I create an opening in the posterior to the bimanual approach with the macro scissor and macro forceps. As Anurag Mishra said, it is very tough cataract. It is very difficult to cut with the vitreous cutter. But in the second case, it was less fibrotic. So we can open it. But Dr. Boishali is there. I know there is another approach is that they create an opening with the continuous capsulation structure. That is the best option. That is the best, but it is very difficult. So in all hands, it is not equally good. Through the side port or main port before implanting the IOL, they create an opening. And then Dr. Boishali will recommend actually Basavadasa, they are always recommending place the IOL behind the posterior capsules, that is reverse optic capture. And the optic will, the haptic will be placed in the back. Am I correct, Dr. Boishali?
Yes, yes.
No, that's haptic in the behind the back, optic in the back. Sorry, back, yeah, that is haptic in the back. Haptic in the back.
Thank you, Doctor.
And they proved it. There is much better approach.
Thank you,
So
Doctor.
different option is there.
Thank you, Dr. Prakash. And thank you, the panelists and the experts for their. Nice. Please. Hello. Yeah. So our next speaker is Dr. Mahbubur Rahman Chaudhary. And we are waiting. You have 15 minutes time to present them.
Chairman, sir, panelists, moderator, Dr. Hussain, and beloved participants. ছোট মানুষ হওয়ার একটা ঝামেলা। ওডিএমের এখানে দাঁড়ালে আমাকে দেখতে হবে না, আমিও আপনাকে দেখতে হবে না, এই জন্য একটু সাইডে দাঁড়িয়েই কথা বলি। Complication, we have seen wonderful management of complication, and complication will happen only to people, only to surgeons who does surgeries. এবং ওটাকে এত বছরের এক্সপিরিয়েন্স দিয়ে যারা আমরা সার্জারি করছি, আমাদের কিন্তু কনফিউশন হয় এবং সেটা কিভাবে ম্যানেজ করবো। এবং Prakash has shown that how beautifully he has managed. So there are two aspects of it. Number one is the medical, and other side is the art of managing the patient. That is also important. Somehow, the art of managing this complication is then not being taught in the medical college, in our residency program. So this is something that we have learned over the years through our experience. And so complication, as we have seen, as we have been discussing, is part of life, and it's going to happen. And how do we tackle it? So now I'm going to deal with the art and the emotional or the psychological aspect of it. And this was a talk that I presented in OSB in the ethical seminar organized by the ethical committee. And Prakash has requested me to deliver the same lecture here. And now, before tackling with complications of other person, we have to tackle the complication of my own surgeries. And these are some of the things that I've learned over the years, and I try to maintain it, and this has given fruits to me. And sometimes there's a human tendency to hide my complication, not to tell to the patient, not to tell to the patient attendant. That's very damaging in the sense that if I don't tell him or her, he will go to other ophthalmologists and he'll find out there was a complication and which I haven't expressed or haven't shared. And that my reputation as a consultant, as an eye doctor, will really go down to him because he came here with high hopes and disappointing him. So I cannot hide it. We have to have the courage to face it and take some deep breath and start counseling the patient right at the operation theater. And may I have some attention here, please? Excuse me. I want some attention here, please. Thank you. So, so this is something that is important. I want to talk to the patient. মা আমি শুরু করেছিলাম কিন্তু মাঝখানে পোস্টের ক্যাপসুলটা যে জায়গায় লেন্সটা লাগাতো সেটা কিন্তু ছেঁড়া, সুতরাং লেন্সটা লাগাতে পারছি না আমি দুঃখিত, কিন্তু আপনার ভিশন কিন্তু আমরা উইল টেক কেয়ার অফ ইট বিকজ আমি এই যে কাজটা করবেন এটা আমার রেটিনাল ডক্টর আমার চেয়ে ভালো করবেন, আমি তার কাছে রেফার করছি এবং আমরা ওটিটা রেডি করছি, হলেই আমরা আপনার কাজটা শেষ করে দেব। এটা একটু সময় লাগছে, আর কোনো কিন্তু অসুবিধা হবে না। কাউন্সিলিং স্টাফ তারপর আমি কিন্তু we asked the attendant to come over to the operation theater and discuss with them that there is a issue here because the posterior capsule was ruptured. Where I'm going to place the lens, that is, there's no space for placing that lens there. So I will take help from my retina surgeon. So the counseling starts. I have disseminated this. And once this has been taken care, the vision will be fine. And there has to be two words, sympathy and empathy. This is very important. If I become that, এটা হতেই পারে আমি আমার সাধ্যমতো আমি চেষ্টা করেছি কিন্তু হয়নি, no, this shouldn't be attitude. We have to have sympathy, empathy. These two words will help us tremendously in our life while we're dealing with complicated cases. And we have to have appropriate referral. As we have discussed, this has fallen down. So my retina person is going to do this much better than I am going to do it. So I want refer this patient to retina person. And we should do it with a communication with the patient and to the referred doctor also. Yeah, this has happened. Let's do the best what is possible. So the appropriate referral is very important. And we cannot de-shoulder. So I have given this patient to the retina person, but the responsibility still lies with me because that was my primary, she is my primary patient. So I have to take the responsibility. So though I have referred this patient to a retina guy, but responsibility lies on me. So I would say that I will follow it up. I'll give a call in the evening at home. How is he doing? Extra care. That's what we want to do. Sometimes in our country, a board formation is a very well accepted for the patient, for the doctors, and in the health sector per se. So if there's a complication, we can form a board consisting of doctors, senior doctors. So that's what we say, that the patient will feel we are giving additional attention to him, and that's how and this is how we care for him, and this will give him added value to hold for the management. And sometimes the financial burden are with the person who had complication. We don't want to exert more financial pressure on him. So this should be shared in the sense that my retina person, whatever he charges, that will be shared by me, not by the patient. So that's how I want to say that we are not putting any financial burden to the patient. But some patients are really arrogant. Some of them, all of us are stage, and they are not satisfied with everything, and they want to go for legal battle and other things. But we have to have strength that we are going to fight back if that is needed. So your legal side also needed to be secure, so that if the patient goes into legal battle, we have to face. But fortunately, over the years of nearly 53 decades plus, I haven't had I haven't had to go to legal battle anywhere, because those precautions that we have taken have helped me a lot. And whenever we are dealing with a complication, it's not, I haven't done it twice. Don't be shy. Don't what you call retract. You face it boldly, because once you show weakness, they will try to take advantage of that. So we have to be bold, and we have to be sympathetic as well. So this is how we should deal with the patient. Now, dealing of complication by other surgeons, and this is, we should treat it like our own, because the colleague has done it. So this is my colleague, he's a friend, his associate. So I have to take care of that patient in the same way. There is a human tendency that either should you react the kidney, no, this is something that we have to take our ego from here and try to do the best that is possible. And this is the lesson that I have learned from my mentor, Professor Nasser Ali. He was involved politically in so many ways, and he has colleagues who are in the opposite camp. And in the meeting, in different forums, we did see debates, and there was criticism. But when a patient came to him from other camp, he was so polite, he was so nice, and he took extra care. That is a lesson that I have learned, and this was amazing, and this has given me fruit over the years. So my young colleagues, this is something that we should take into consideration while dealing with complication by other surgeons. And we have to be humble. As we said, we need to control our ego. This is not the time to show my ego. And we should communicate with the primary surgeon that this has happened. He has come to me, and I have done, I think you have done the best thing. But if I have any added suggestion, I will communicate to the primary surgeon so that he knows that we are in the same team. And finally, please, let's not make that patient my patient, in the sense that we should go back to the primary surgeon who has done the complication. So this is something we have to take into account. And doing all this thing, you can become a great ophthalmologist and a kind human being. And for my new colleague that I'm sitting behind, I'm just taking 2 minutes just to say that a good behavior on our part is the most important factor in your practice. So keep this in mind. Be a good general ophthalmologist before you take a subspecialty. But subspecialty is a must. We have to take. And it's a group practice where we can tackle the complication much easier and the same under one thing. And this is a continuous learning, and research is something where we lack. So this is something I would emphasize on my young colleagues to look into this part. And there has to be work-life balance, and prioritize your health is important. You can have some hobbies to take you forward. And with this, viewers, I thank you all for your kind attention. Thank you.
Thank you, Dr. Mahbub Rahman Chaudhary. Now I will request Dr. Karim, you want to give any comment?
Thank you. Thank you, Professor Mahbub Rahman sir, for your nice presentation. Actually, event is there if surgery we do. So everybody face these types of complication. It's a usual. For this, actually, most of the medical legal matters comes after complication is because of less communication between the patients and the doctor. So what most of the doctor usually do, if there are complications, they try to avoid the patient. They just trying to de-shouldering the patient to others. So try to avoid. That makes a gap between the patient and the doctor. So the most important is if there's complication, what said in the lecture, that we should explain immediately to the patient attendance, and all other colleagues should know the complication has done, happened. So every colleagues will come and they will explain. So it may happen if I say this has happened, it's complication, but the others not telling same thing. Counseling them, they sometimes feel that we are not taking their proper care of the patient. So like we can consult everybody with the patient. What we do in our hospital is everybody we go to the patient, we tell this may happen, we're seeing, we're trying to do something for you. So ultimately the patient know they're trying best for our betterment. That helps to counsel them, and ultimately the patient understand this complication is there, it happens, so it's acceptable. Otherwise, there may be problem. Other thing I can say, some patient before surgery also, if is there any doubt of complication like hypermature cataract, subluxation, the prognosis is not good, we should explain to the patient that you have this type of cataract or you have this type of condition, there may be some complications, so you be prepared, your vision may not be improved properly. So that will also help up to some extent. So after all, main thing is we should have very good friendship with the patients, even normally, not only after complication, normally also, so that this bridge will helps to manage most of the things. Thank you so much.
Yes, sir. So I invite questions or any comment from our guests, speakers. Dr. Anurag, you want to say anything? Yes. Okay, thank you. So Dr. Mahbub Rahman Chaudhary has raised an important question. An important aspect of our patient management is the complication, and once there is a complication, how we tackle it, how we make our patients happy and satisfied. So we have so many examples. I can just share two example. Sometimes when I implant the IOL, the lens gets torn, and then particularly haptics gets torn. So it's at that moment, is most important part is to replace the lens. If you don't have a replacement, then you can wait the patient, tell the patient, then you have to come again on that, then I'll put that. So many of the time I just manage with this torn lens, just putting into the either optic capturing into the capsule, and keeping the part of the haptics outside. So I survived 2 or 3 times. Once I just did the same thing, And on the next day, I found that the patient is having reasonably good vision, having no problem, but he started seeing from the 1 week and extra, because the lens was not in the center. So he was having an extra image in the down. So I dilated the people. I found that the lens is not in the position. And I had to convince him to take him to the OT. And Dr. Mahbub Chaudhary has said that you cannot charge for that. You cannot charge for the next lens. We had to take the responsibility. We have replaced the lens, and the patient was very happy. So it is the way we manage the patient is that you have to give them the confidence that I'm taking it properly. I'm taking it with serious measures. So patient will be very happy, I think. Any other comment, anybody? Sometimes the black spots gives us the patient says this, well, I'm seeing well, everything fine, but the black spots are still there. So this has to be dealt with again in a way. One patient wanted to sue me because you have this black spot. I came to you for this black spots, not for the cataract, and this 6/6 দেখে আমি কি করব? আমার দরকার নাই 6/6, আমার black spot ঠিক করে দেন. So you have to deal with this, and then the patient just was ready to sue. So then I said that I'll form a board, or you can come to the other colleagues, talk with them. If anybody says there's something wrong, then I'll take the responsibility. Then eventually it was managed as this happens. Thank you very much. Thank you.
Thank you. I want to sorry. I want to make a comment on very renowned cataract surgeon, Dr. Mahbub Rahman Chaudhary, and just the most important thing, it just touched my heart that we must not hide, not hide, actually, we must not tell any negative comments about the other surgeons. This is very much important. It must be a good practice. I'm telling about two things. One is we, the seniors, have to encourage the juniors. Juniors have completed their training and they start their surgery. 1 or 2 complications can be happened, and it can be referred to the seniors. Sometimes I want to tell in Bengali, oh, ki sarbonash hoye geche, apnar chok to shesh hoye geche, ki kore fello she. This type of comment we must not give, and nobody should utter such type of comments. This will just discourage juniors, and also we cannot because the second one is there is some competitions like 2 or 3 very famous surgeons in a city. So we should not find out the others' complications, and we must not tell about the negative things to the patient. I think these are very much important, and this will make our good association. This will make our good bonding, and everybody can be in a problem anytime. So somebody should help you. So we don't know who will be in the danger, who will be in an accident. So I think we should have a mutual respect with each other. Thank you.
Thank you. Our next speaker is Dr. Vaisali Vasavada. She's joining us here in the webinar. I will request Dr. Vaisali Vasavada to present her paper.
Thank you so much. And once again, I'm very happy to be presenting here. And I think before I start my talk, I really found this talk by Professor Dr. Mahbub Rahman so educative myself. And I think I've learned quite a bit. And I find 2 things also very useful, that it is very important what we speak and what we write in our case papers. So it starts in the OT. When you have a complication, sometimes there will be, obviously you are a little more tense. So no loose comments, oh, there is this happened, I should not have done this. Or sometimes the assistants are a little more tense and they are not able to come up with the right instrument at the right time. So what we speak in the OT, the patient is not under GA. So we need to be very careful, and we need to be very calm in our language. And this comes only with practice and telling ourselves that be calm, don't express or don't talk words that the patients will pick up, and then later in a legal situation they can use that. In fact, I can give an example. There was a legal suit on a retinal surgeon because he was humming a song when he was injecting an intravitreal anti-VEGF. So patient had a perfect outcome, but the patient said my doctor was singing, and that means he was not focusing on me. So I think things like that. Second is when we write in these cases, whether you have a paper case sheet or you have an electronic record, this is a legal document. If God forbid something happens, so we need to document very properly each and every finding at every visit, including suppose the patient said something or you told the patient something, that should be noted down, because this can be a big help in case something happens. So I think that were my 2 points. And I'll now come to my topic and stick to time. I have no financial interest, but this really burning topic on what should we do if an infant, particularly any child below 2 years, but particularly an infant, comes to us and the question is whether or not to implant an IOL. So I think we all understand that the objective of a pediatric cataract surgery is not only technical in terms of giving a clear cornea or a safe eye, but more importantly functional, because we are looking at binocularity, we are looking at amblyopia and vision, developing vision to its maximum potential. If we argue in a small child, baby below 1 year of age, why should we implant an IOL? I think we need to give early visual rehabilitation, because these children don't often wear glasses or contact lenses. They come from backgrounds where they may not even be able to afford frequent change in glasses also, leave alone contact lenses. So that's the thing. In our regions, in India and Bangladesh, contact lenses are a very impractical means of aphakic rehabilitation. And the fact that we need to give them at least partial visual input constantly, which can be done with an IOL. Now, why would we not implant? The other flip side of it. I think like Dr. Prakash very rightly already made the point that if you cannot implant in the capsular bag, then it is best not to implant in any child below the age of 1 year. Because, and generally also these eyes are at a higher risk of inflammation of glaucoma and of posterior capsular opacification. So these are the reasons which make it more challenging to implant. Above 2 years of age, I think now globally we all know that it's okay to put in an IOL, but below 1 year of age, and particularly if it is a unilateral cataract. In bilateral cataracts, it's still okay to manage with glasses, but unilateral cataract is the real problem. So what do most people follow? This is, a lot of it is taken from published literature. For primary IOL implantation at any age, whether it's 3 months, 6 months, 1 year, contraindication is a horizontal corneal diameter of less than 10 millimeter. For us, it used to be less than 9.5, but now we have stepped it up to less than 10 millimeter. Microphthalmos, that means any baby with an axial length of less than 17 millimeter, we don't implant an IOL primarily. And like I said, if intraoperatively I have too much iris manipulation or I cannot put the lens in the bag, then I will leave that child aphakic for that time. Now, what do international publications say? The American Academy of Ophthalmology in 2019 published a report where it basically said that IOL implantation primarily is not recommended in children under 6 months of age. However, above 6 months of age also they are giving a caution that you better perform only in hands of surgeons who are expert or experienced in doing this. There's a landmark study, and in many, wherever we go, a lot of surgeons quote this paper, which is an American multicentric study, the infant aphakia treatment study. Now here they studied children less than 7 months of age who underwent cataract surgery for a unilateral cataract, and they randomly put in an IOL versus did not. So what they found at about 10 years of follow-up is that they do not advise primary IOL implantation for children under 7 months of age who have a unilateral cataract. Now, it's very important to understand that they say this because there was more rate of resurgery, more surgery for PCO and for synechiae or membrane formation in pseudophakic eyes. So that is one reason why they recommend to all of us not to do it. But we live in a different geography, we live in a different economic situation where we don't have these kind of very controlled follow-up. We may not be able to do anesthesia evaluations all the time. Financial constraints are a big problem. So in this study that they showed, and which is being quoted all over the world, people forget that the optometrists used to visit the children at home. They used to give contact lenses free of charge, and even if they lost or broke a lens, a new one was provided. And these are all unilateral cataracts. So unilateral cataract anyway, most of the times may have some form of either a persistent fetal vasculature or some abnormality which anyway may preclude IOL implantation. So I think everything said and done, in our region, if I were to say in India, in Bangladesh, in most of the Asia Pacific, if the axial length and the corneal diameter are okay, and if you have enough experience in a unilateral cataract, I would not hesitate in putting a primary in the bag IOL in a child who is about 2 months of age, 1.5 to 2 months of age. So I think that we should understand what we are dealing with and how well we can follow the child up before we do anything. Now we come to bilateral cataracts, and until very recently, there was no good evidence on this. And in way back in 2018, we published this randomized clinical trial in the American Journal of Ophthalmology, where basically we took children below the age of 2 years. Half of them were left aphakic bilaterally, half were left primary IOL bilaterally. And what we found was basically, we were looking at mainly the complications, glaucoma, visual axis obscuration, and inflammatory changes, as well as how well and how fast the vision develops. So to summarize, what we found in this landmark trial was that the incidence of post-operative complications, including glaucoma, was comparable between the groups. When you performed a posterior capsulorhexis, when you performed an anterior vitrectomy and put a lens in the bag, the complications are comparable. Although there were more posterior synechiae in pseudophakic eyes, but I think just having a synechiae itself should not preclude or should not be a contraindication for IOL implantation. But what is very important is that these children at 5 years follow-up, which was the last follow-up in our study, at 5 years, both the groups had similar vision. But the pseudophakic eye started getting a better vision, 612 or more on the Cardiff or other charts, much faster than the aphakic children. So what is very important is that the vision rehabilitation or the rate at which your vision improves after cataract surgery was definitely faster when primary IOL implantation was done. And 50% of the children in this study, although this included 0 to 2 years, 50% children were below the age of 1 year. So it holds true even for infants. Another study from the US also in the following year showed that in children below the age of 7 months with bilateral cataracts, the visual acuity was comparable, although they did say that IOL increases the risk of a PCO or a visual axis obscuration. So I think in our subcontinent, the main thing is how well you can follow up these children and how well you can rehabilitate these children and what is your surgical comfort. I wouldn't say skill, everybody is skilled, but your and your team's comfort level in dealing with these children. Moving on, if you do put an IOL, what material? For me, without any commercial bias, it is hydrophobic acrylic, whether it's a 3-piece or a single piece, both are equally good. It really depends on where and how you are putting them. But a hydrophilic, I would not put in an infant because it's a guarantee for visual axis obscuration and very soon this will happen. Now, where to place? Again, like Professor Prakash highlighted this, I don't need to stress, but if we cannot put it in the capsular bag or put the haptics in the sulcus of a 3-piece lens and push the optic behind the capsular axis margin, then it is better to either put a 3-piece entirely in the sulcus, never put a single piece hydrophilic or hydrophobic IOL in the ciliary sulcus, whether it's a child or whether it's an adult, because these are very thick haptics, square round edges, they are not, and they will invariably cause uveitis as well as glaucoma in these pediatric eyes. Now let's look at what are the options. One option is you perform a manual and anterior and posterior capsulorhexis and do a vitrectomy because it's a small child, and then you fill in cohesive viscoelastic sodium hyaluronate and then put in a single piece hydrophobic acrylic IOL or a 3-piece acrylic IOL in the capsular bag. So this approach is very good, but it is extremely difficult for any surgeon to perform a predictable posterior capsular rhexis in a child, particularly who is below the age of 6 months. So this is not an ego issue. It doesn't, there are no more marks or added advantage for performing a manual rhexis and proving that I did this or I didn't do that. So this is one option, which is the option number 1. But if you feel, and I often do this even now, that if I'm not confident of being able to perform a posterior capsular rhexis, what I will do is I perform an anterior capsular rhexis and do a bimanual IA. Now this is where we are. Now put in that lens in the capsular bag, and after that use the vitrector and perform a posterior capsulotomy and anterior vitrectomy. Now here again, it's important, like previous speakers have stressed, the cut rate should be maximum. Now this is an old video where 2500 was my maximum cut rate. Now we have up to 4000, 5000 cut rates. But you can see that even with this, the kind of margin is very strong. So you get a very good margin and a very controlled margin. I like to put the vitrector through the pars plana. In a child's eye, we must remember, in an infant's eye, that the pars plana, we don't know where it is. So don't go beyond 1.5 millimeters. Don't go at 2 millimeters. Most likely you are behind the pars plana. So around 1.5 millimeters, I insert my vitrector and do a capsulectomy vitrectomy. And then the third question, which also Professor Prakash was mentioning, can we avoid vitrectomy? Because whether you go through the limbus or you go from behind, you are eating up that vitreous, which has a very fixed gradient of vitamin C or ascorbate. And that is one of the important factors that has been shown to cause glaucoma or oxidative damage when you damage the gradient of oxygen as well as vitamin C concentration across the vitreous. So this Professor Stanley Chang, who's an authority on glaucoma, many years given this hypothesis that if you do a vitrectomy, you are more likely to get glaucoma because you are causing a disturbance in the vitamin C, the ascorbate levels, and the oxygen-free radicals. So this technique of optic capture, which was first described by Professor Dr. Howard Gimbel from Canada in pediatric eyes, where you perform an anterior and posterior capsular rhexis, and then put a 3-piece hydrophobic acrylic IOL in the capsular bag, both the haptics and the optic. And after that, you push the optic behind the posterior capsular rhexis margin, which is what we will see. So this is a cataract where you did, and you can see the anterior capsular rhexis. Now, at this point, I will pause and you can see that there is an anterior posterior capsular rhexis, there is a posterior capsular rhexis, and this 3-piece hydrophobic acrylic IOL is in the capsular bag. After having done that, no vitrectomy is performed, and using a Lester hook or a Coughlin's hook, just sort of slide the optic through the posterior capsule. You'll need to tilt it behind a little bit and gently nudge it on one side and then the other. So this dumbbell shape is a confirmation that your IOL is captured. What it does is that the anterior and posterior capsules will fuse above the IOL optic eventually, and therefore they avoid any proliferations of lens epithelial cells to the center. So you will have no PCO or a very late development of PCO. But what is also very important is that the fusion of the anterior and posterior capsules also locks in the lens or maintains the stability of the lens in the anterior-posterior direction. So this is a follow-up. Now this is an animation where we are trying to show what happens when an optic is captured, because like I said, the obvious advantage is that you prevent the lens epithelial cells from reaching the center. But something that comes as a very corollary advantage is that the lens will never move if you capture it through the posterior capsular rhexis. So wherever you can, this is again not an easy technique, but I think above 6 months, definitely it can be tried. Worst case, if your posterior capsular rhexis ends up smaller or larger and you cannot capture, you can always put the same lens in the bag and then do a vitrectomy. And we published the 1-year outcomes, but now we are looking at 7-year follow-up of these children. And we compared randomly one group which had the standard anterior posterior axis vitrectomy and in the bag IOL. And the other group, which had only optic capture without any vitrectomy, these were all children below the age of 4 years, so not older children. And the visual axis obscuration is almost nil. You will see some fibrosis or some phimosis of the fused capsular margins, but usually the central axis remains very clear and they are not causing any problems. Even glaucoma or inflammation is not an issue, as we are seeing. So I think the last couple of slides of my presentation, if you do implant in an infant particularly, but any child below the age of 2 years, only do that if we think we can do a meticulous and regular follow-up, because they may need a PCO surgery, they may have some other problems, membrane, which you will need to treat. So only if you can follow up, then you implant an IOL, otherwise leave the child aphakic. You may need examinations under anesthesia every now and then, not every visit maybe, but maybe once a year at least. And again, like was being discussed in the previous talk after Dr. Mahboobur's talk, that you have to discuss potential problems and resurgeries with the parents and caregivers. Pediatric IOL implantation at any age, particularly in younger children, may need second surgeries for VAO, for glaucoma, for anything, even if it's a perfect surgery. So this has to be discussed with the parents. And I think older children we should all start with, and once we feel more confident, once our team, that means the optometrists, anesthetists, everybody is more used to older children, then we do, and think 100 times before we do a child below the age of 12 months. Thank you.
Thank you very much, Dr. Vaishali, for giving us an illuminating lecture on the pediatric cataract management. And this is also full of informations of researches of several years. So it's a wonderful presentation from you. We are running short of time, so we will not take any comments or questions. We will next we'll request Dr. Anurag Misra to give his presentation. At the end, we'll try to give take some questions from the audience.
Thank you so much, sir. In all probabilities, this will be the last time that I will be speaking through the microphone on this particular visit to Bangladesh of mine. I thoroughly enjoyed every moment of it. Good afternoon, ladies and gentlemen. Good afternoon, Vaishali. Greetings and regards from the land of Jagannath. This particular deliberation would be obviously, needless to mention, a little technologically packed. So I would show you the printout and the observations that are made by various machines that we use in the pre-operative room. And you're free to ask me later on after the talk is over, even if we are running short of time, what exactly is the portfolio or the specificity or the exploit of a particular machine. Because without technology, without machines, we cannot decide which patient is perfectly suited to receive what kind of an IOL. Although the title of the topic was such that Professor Prakash wanted me to speak on the advanced technology IOLs, the trifocals in particular. So I've titled the topic like that. We will discuss about the trifocals there. But before that, let's focus on the must-see aspects. Before we go to the should-see and the better-to-see aspects, the must-see aspects we should see in any patient that has come to us, be it a monofocal implant as well. The first thing we see is the pre-existing conditions. And one of the major ones in that is astigmatism. In my practice, almost 45 to 50% now is historic IOL. So that is the kind of enormous impact astigmatism has in our practice. It's just that we don't see it properly. This particular patient had come to us with a specific request of a trifocal implant. We saw that there is a 0.5 astigmatism or cylindrical residual that's likely to stay. Now, if you promise the patient a spectacle independence and post-operatively is left with a 0.6 astigmatism, neither the patient is going to have a good distant vision, nor intermediate, nor near. So one aspect distorted, all the distance will be distorted. Luckily, this patient selected femto laser platform for himself. So you can see that there is an arcuate incision planning that has been done on the cornea to neutralize the astigmatism. Had that not been the case, we would have gone on and decided on a toy. Apart from astigmatism, the other things are, if there is any history of laser vision correction, if a LASIK has been done, a PRK has been done, that history has to be taken into account. If there is a strabismus per se is not a contraindication for trifocals. You can still go ahead and put it, provided there is no macular separation. If there is a macular separation, the visual potential is not good. The visual potential is not 100%. They have a lot of crowding phenomenon. So if the patient is amblyopic, moderate to dense, or if there's a macular separation, better stay away from the ATIs like the trifocals. So these are the pre-existing conditions that we should look at. Reliability indices in any biometry machine are important for us to look at. If we are using an IR Master 700, and I think most of us would be using an IR Master 700, this is the printout, not the printout exactly, the screen. This is how it looks like when you look at the analysis page. Since it shows you at least two measurements back to back, you should look at the difference the keratometric indices bear and the axiometric indices bear. A difference more than 0.02 for keratometry and 0.05 for axiometry between two readings is not acceptable. If it is more than that, the standard deviation is more than what is acceptable. So you should redo the readings, retake the readings, make the standard deviation come below 0.02 or 0.05. Until that point in time, do not accept the reading. The 700 also gives us the foveal pit so that we know from where the light has, which point of the retina the light has hit and come back. So if there is no foveal contour, like on the right hand side of the screen, then that particular reading has to be discarded. This is about the 700. If you're using any other biometry, like the Anterion from Heidelberg, so that doesn't give you the foveal pit. But what it does give you is an auto tracking mechanism. It's an excellent tracker. The moment the patient tries to look at the instrument, the light immediately starts tracking the center of the cornea and the visual axis actually. So that's how it does it. Argos from Alcon, that has got a corneal vortex tracking. If you look at the green band there are two limits of that green band, and within those two lines of the green band, the corneal vortex has to be there. So for you to accept the reading, that has to be the case. The other thing is the ILM tracking. If you look at the ILM down below, we know that at the fovea, the center of the fovea, the ILM is the thinnest. So the machine understands that. But it's just that the optometrist also has to have an idea that what should be the ILM thickness ideally at the center of the fovea to be able to accept that reading. So this is about the Argos, the Anterion, and the 700 different machines, but all of them have reliability indices. If you look at the corneal, the keratometric findings, look at this patient, for example, one of our patients in the OD, the delta, the cylinder has shown to be minus 1.09. Can you see that? Opt-out, 1.09. All right. Now, if you split the three readings that have been taken by the machine, in the first reading, the cylinder is 0.27, the delta is 0.27. Can you see that? In the second, it is 1.56, and in the third, it's 1.30. Do we have a pointer? Do we have a laser pointer? All right. So since it averages down to three readings, it has falsely shown us the cylinder to be 1.09. It should be more. Because in the first reading, when the mass are taken, one of the mass has been cross-marked. So this reading should be outrightly discarded. It should be redone. If you compare that with the left eye, the cylinder value is 0.95. So that's where it should be. Okay. So these are the reliability indices. Another must-see aspect is the ocular surface. If you have access to one of these, the ocular surface suite or the tri-eye suite, it will give you different aspects of the ocular surface. One of the chief ones being the lipid layer. In any subtle meibomian gland disease, the lipid layer has to be low. But if you don't have access to these expensive equipments, you can simply do a tear cut-off time test. But you must look at the ocular surface when you're planning a trifocal in particular. Because when we take the keratometry, we do not look at the cornea, we actually measure the tear film that's in front of the cornea, right? So if the cornea doesn't have a good tear film coverage, then the whole reading goes haywire. So the ocular surface is something we must see. And this is something I keep on emphasizing. Look at the pupillary size before you select any patient for trifocal. For example, if you look at this patient was very keen to have a trifocal implanted. Now, in your preoperative room, ideally it should be a dark room, okay? And it should have adequate lights fitted into it. Once you take the pupillary size in a mesopic condition, you should then switch on all the lights and take the measurement, repeat the measurement in photopic conditions. Both the pupillary sizes are important. Why? Because the trifocals have the surface modification in one particular zone. The panoptics has in 4.5 millimeters, the geometric has in 3.25, like that. All right. So in a mesopic condition, when the patient is driving, say the patient is driving, okay, inside the cabin of the car, it's a mesopic situation that exists. The pupil has to dilate. If the pupil dilates under mesopic conditions, if it's not very small, if it dilates, then the pupil assumes a size which is bigger than the surface changes on the trifocal. So the peripheral girdle is always used for distance, and the patient can look at the traffic well. If the pupil stays small, like in this patient, this is a mesopic pupil, and look at the pupillary size, it's 2.9. So what happens is when the patient drives, the rings pattern on the trifocal IOLs come right at the center of the pupil and they distort the vision. So the driving is not very comfortable. Converse of that, high photopic pupil. So when the photopic conditions exist, when the patient tries to read, the pupil has to be small. The ring design covers the whole pupillary diameter, and the patient has an excellent near vision. Not with this case, he has 4.2 millimeters. So in my opinion, I have kept the cutoff to be 3.5 millimeters. If 3.5, more than 3.5 in photopic and less than 3.5 in photopic is something I do not select the patients to receive a trifocal image. Apart from that, the posterior pole, of course, is something that must be looked at. We are using an ILMaster 700, then it gives us the posterior pole picture, and sometimes it's evident, then we can subject them to an OCT. An OCT is a must-have equipment, even if you are a pure cataract surgeon and not doing retina at all, just like me. I don't even have a retina colleague in my setup, but OCT machine is a must for you, even to save you from medical legal aspects. The posterior pole must be looked at. So these are the must-sees. Now coming to the shoulds. We know that there are two angles that exist. We talk about the angle alpha and the angle kappa a lot. I think all of you must have heard that. Angle kappa is a three-dimensional angle, of course. The two-dimensional representation of angle kappa is called mu. Okay. Now there are 3 points. One is the optical axis. The optical axis is the joining point of all the 4 Purkinje images. Next is the pupillary axis, which is the center of the pupil or the center of the capsular bag, essentially, the center of the capsular bag. And then the visual axis, which joins the fovea with the object. All these 3 lines could be separately placed in the eye. What we have to remember is the limbal axis or the pupillary axis, the center of the bag is where the IOL is going to be centered. We cannot change that. Okay. The optical axis is through which the lights are passing, because it joins the 4 Purkinje images. And the visual axis is through which the patient is getting to see the object. So the distance between the pupillary axis and the limbal axis, or the pupillary axis and the optical axis, is what is the angle kappa. So if that is more as in more than 0.4, I've kept angle kappa or chord mu to 0.4. If it is more than 0.4, then what happens is the light travels through the substance of the lens and falls on the ring patterns of the trifocal IOLs and causes a lot of photic phenomena. You have a lot of this photoxia. Those patients are never happy. So more than 0.4 angle kappa is a strict no-no for me when it comes to trifocal implants. So this is what is the case here. 0.533 is the angle kappa. When it comes to the angle alpha, which is the distance between the optical axis and the visual axis, there it would depend on the central bull's eye of the trifocal design. Like in panoptics, they have a central bull's eye of 1.2 millimeters, so till 0.6 you can go. Like in geometric, they have a 0.7, so till 0.3, 0.35 or 0.4 you can go. So it's that calculation that should come into play. There are different machines that measure the angle kappa though. Angle alpha is measured only by the eye trace and no other machine is able to measure that. Lens tilt, sometimes there is a lens tilt and that acts both ways. At times you see that the patient is not wearing any glasses, but when you look at the corneal meridians and do a keratometry, you find that there is a difference and the patient is an astigmatic. What happens there is the corneal astigmatism is neutralized by the lenticular astigmatism. So the cornea is tilted this way, the lens is tilted that way, so they neutralize each other. So there, if you are operating on the cataract of that patient, the lenticular astigmatism is withdrawn, the corneal astigmatism will manifest, so you would need a toric IOL to neutralize that. One of the essential tools to diagnose the lens tilt is the anterior segment OCT, which shows you here that the lens axis and the optical axis are separately placed to one another. That will show you the lens tilt. What will also show you the lens tilt is the reading on the eye trace. The internal plane, all the higher order aberrations are elevated. So that's also an indication where the lens tilt is. Topography is seen on the cornea wherever it is available if you have access to this machine, just to see the symmetry of the bow tie. This is a symmetric bow tie. This is a regular astigmatism. A toric IOL should ideally be placed here, but if an asymmetric or irregular astigmatism exists, the toric IOL is not going to work. Angle alpha, we just discussed what angle alpha is. This particular patient had 0.605. Now, the MTF curve, the modulation transfer function curve, as is plotted by the eye trace again. The eye trace is a wonderful tool. Does anybody use an eye trace here? All right, so it's an excellent aberrometer coming in from Tracy Technologies. Start using this machine, you'll fall in love with it within 15 days. It's such fun to work with this machine. So the modulation transfer function is essentially something that measures the contrast sensitivity. You have a square which is red shaded down below. Can you see that? So the critical contrast sensitivity is 40% at 10 cycles per degree. So on the x-axis, you have cycles per degree. On the y-axis, you have 40%. So 40% or 0.4 at 10 cycles per degree is the cutoff limit. Now, you have three such curves. Down below, you have that plotted from the cornea. Up above, you have from the internal and then the total eye. You're not worried by what the internal plane shows you, because this patient has cataract. Obviously, the contrast will be reduced. We all know that. What is important for us to look at is the cornea. If the corneal contrast is already bisecting that critical red shaded square, then that patient is a bad candidate for trifocal, because the contrast is already reduced. You are going to reduce it even further by putting in a trifocal. This picture, vis-a-vis the next, which comes up, look at this picture. The cornea's contrast is fine. The MTF is well above the square. The internal plane though is reduced. This patient is a good candidate for a trifocal. So that's what the MTF curve shows. This is the refraction map, again plotted from the eye trace. This refraction map is very distorted. It takes the reading from the central 1 millimeter from the cornea and the eye combined. So the central 1 millimeter reading, if it's distorted, again, this patient, whatever you try, this patient is very unlikely to be happy with the trifocal exam. So better stay away from it. Vis-a-vis that, this particular refraction map is perfectly suited. No yellows, no reds, no oranges, all green, and they look very regular from the central 1 millimeter scan. So this patient is an ideal candidate. Dysfunctional lens index actually is not an indication of contraindication. I just showed you for the heck of it. A lot of people come to us nowadays, particularly the young individuals, having a best corrected visual acuity of 6.9, but still they're not happy. I mean, pre-operative, 6.9. You see that there's some amount of cortical opacity or an early PSCC. You wonder why this patient is not happy or why this patient has a lot of strain, particularly if he or she is a system user, uses a lot of computer strain. You subject the patient to an eye trace, and this is what comes up. Although the patient is able to see the E, this is how distorted it is. And the DLI, the dysfunctional lens index, also has a score to it. Right now, it is very low at 2.05. Even if it is in the 5 to 5.5 range, in a young patient who's a computer professional, you're still allowed to operate that cataract. These cataracts are called Zernicase cataracts nowadays. The new nomenclature that has come up. It's called Zernicase cataract, and they actually are very, very symptomatic. So go ahead and operate these patients. even if the best corrected visual acuity is 6.9 or even 6.6 partial. Lastly, the web front map from the eye trace, everything else becoming normal or showing normal. All the values are normal, but if you look at the web front map there, it shows all the parts are showing there. Now, mind you, this sort of a map can also come if the patient's eye is dry. So it doesn't necessarily show an organic defect. It can also be as a result of the dry eyes. I would certainly harp on this, the endothelial cell count. Everybody should have access to a specular microscope. If you're a plain cataract surgeon, doesn't cost much, but saves you from a lot of blemishes post-operatively. Like in this patient, you have a cell density of 1840 and a hexagonal cell percentage of 0. Absolute red flags. These patients, you have to be very careful. On the slit lamp, you might not find clear-cut evidences of corneal cut, but still they would have long-standing and non-dissolving corneal edema post-operatively. So save yourself from the blushes and get a specular microscope is what I would recommend. We were discussing, Rajiv sir, yesterday about this planning cockpit and image guidance at your center. So this is what it does. Again, there are two systems. One is Callisto from Zeiss, one is Variant from Alcon. Both of them priced equally, expensive for the explicits they have, but still it is, for me, it is very, very important. Look at this patient example. You will understand in a flash what I'm trying to say. Look at this patient example. This patient came to the OPD and wanted surgery on the same day. All right. If you look at the recommendation, it's P3 is what the machine recommends. P3 toric is what the patient recommends, is what the machine recommends. And down below, you have the residual. The residual has been shown to be around 0.01. Look at the primary incision. The primary incision is somewhere around here, and it shows that it's 2.2, which is my normal incision width. I contacted the local distributor, and the distributor said that we don't have a T3 available. So this patient surgery cannot be taken up today. You have two choices. One, you postpone and fix up on another date. Two, if you want, we can send you a T2. But if a T2 is implanted, then a T3 is required. Obviously, the patient will have some amount of residual serum, more amount of residual serum. So what do? We asked Variant, what do we do? What Variant suggested was, we can go ahead and put in a T2, but the extra amount of cylinder correction has to be done by extending the primary incision from 2.2 to 2.8. So that's exactly what has been planned here. The primary incision has been increased to 2.8, and then if you implant a T2, then the residual would be the same. Nothing much in this to understand, but the reason why I say it's fun to work with this machine is that when it's my practice to sit with my optometrist for the during the lunch break of 15 minutes that we have in my hospital and discuss these, and a lot of these interesting things come up, and you can customize and change things here and there. The ultimate goal and objective of which, like all of us, like everybody present in this room and beyond in the world, is to achieve 100% satisfaction. Thank you so much for the invite and the opportunity, ladies and gentlemen. I sign off with this. Thank you.
Thank you, Dr. Anurag Mishra, for giving us a wonderful insight of the difficult optics of the trifocal lens implantation. As we are really running short of time, we cannot have any questions. And I will request our chair of this session, Dr. Shamim, to give his concluding remarks. Have an inaugural session after this, and we'll have to finish it by 5:30, as we have to, the guests from Dhaka will have to leave this station within 5:30.
Thank you, Dr. Zafar Khalid. Thanks to everybody. Very nice, illuminating, and knowledgeable session probably we had in this time. First, I like to thank Professor Prakash that the effort for the complicated cataract he has taken, and he have shown us this is very nice, encouraging, and matter of learning. Then Professor Mahbub sir, again we learned that counsel to the patient, and have a close contact with the patient and patient's attendant especially if there is any complication occurs, so that they will not be diverted from your station. They will be happy. Counsel and counseling, close contact. And my teacher, Professor Rabil Hussain, used to tell, yes, never hide. And the operation note, operation description should be like mathematics. Should be like mathematics, so that you will know later on what happened. Somebody of your colleagues know later on that what happened. And otherwise, if this patient goes to other consultant or doctor, that if that doctor tells that, yes, this happened, doctor didn't tell you, then this is not good. So counsel and tell everything nicely in positive way. That is our learning. And Dr. Anurag, yes, very much precaution and preciseness to take before going to toricity. Even with very much care and caution, patient might be dissatisfied. So there is still more to have check for going to toric and lens. Thank you, everybody. Vaishali, she is all time. She is giving us some new aspect. And what I remind that in one session, I don't know, in the, she told about that the fluid even comes shower behind the vitreous, which might cause the vitreous upturn. That I kept in mind. So thank you, Vaishali. And also my guru, Dr. Vasavada, I went to your place, Dr. Vasavada's place before Prakash going there. And I give namaskar to Dr. Vasavada. Thanks. Thank you, everybody. Mr. Malik, sir is here. Thank you, everybody. And have a nice time. And my moderator and my panelist, everybody, thank you very much. Thanks again.
We got to hear a great deal of expert discussions from the legends of the field of ophthalmology in this session. At the end of third session, I welcome you all to the inauguration ceremony of today's event. This session will be chaired by Lion Nasiruddin Chaudhuri, MJF, Honorable Chairman. With the recitation of the Holy Quran by Professor Dr. Muzammil Haq Sharifi.